Hello, everyone. Welcome to the Academy of Online Radiology Education. My name is Sara Momtazmanesh, and I'm a postdoctoral research fellow in the Department of Radiology at Johns Hopkins University. I'm genuinely excited to be here and to contribute to the ACORE blog series. Today, we are discussing MR enterography in Crohn's disease, and specifically whether intravenous contrast is still necessary or whether a shorter, contrast-free protocol can give us the same information. Before we begin, I want to thank my senior editors, Dr. Kart, Dr. Stewart, and Dr. Sayes for their guidance and continued support of the ACORE blog series. The paper is comparison of conventional versus abbreviated MR enterography assessing disease activity and complications in Crohn's disease, published in Radiology in May 2026, and a special credit to the investigator team for a well-designed, carefully executed study. MR enterography, or MRE, has become central to Crohn's disease care. It's non-invasive, radiation-free, and shows both the bowel wall and complications like strictures, fistulas, and abscesses. Symptoms can be an unreliable guide to what's happening in the bowel, so we lean on imaging to direct treatment, and patients are often scanned again and again over the course of their disease. But the standard protocol adds intravenous gadolinium and an antiperistaltic agent, which take more time, cost more, and requires an IV access. That raises the question whether we can simplify the protocol without losing information. Earlier work suggests that dropping gadolinium may not meaningfully reduce accuracy for detecting inflammation. One thing that's been less explored is whether different radiologists would read an abbreviated protocol the same way, something that's especially important for serial monitoring and scoring. To answer that, the investigators compared two protocols for detecting Crohn's disease activity and complications. One is abbreviated and contrast-free, called AMRE, and the other is full contrast-enhanced protocol called CMRE. There are two main endpoints. The first is inter-reader agreement, which means do different radiologists agree with each other? The second is intra-reader concordance, meaning that does the same radiologist make the same call on both protocols? And since the readers came from different regions and experience levels, the key question is whether agreement is maintained across readers regardless of region or experience. As a secondary aim, they also tested the simplified MR index of activity, the S-MARIA score, against ileocolonoscopy in a subset of cases, this time measuring accuracy. The study was a retrospective single-center secondary analysis with 60 participants and 80 examinations, 51 before biologic treatment and 29 at the week 46 follow-up. Each exam was read under two protocols. The abbreviated protocol is the T2 and balanced SSFV sequences, and the contrast-enhanced protocol adds the T1 sequences, before and after gadolinium, along with the antiperistaltic agent. However, the abbreviated exams weren't acquired separately. Each was built by pulling just the T2 and balanced SSFB images out of the full study. So both reads came from the same scan, and the only thing separating them was the contrast sequence. Additionally, neither protocol used diffusion-weighted imaging, and the case mix finally was selected to reflect a cross-section of Crohn's disease. Every examination was read by 10 abdominal radiologists based in the United States, Europe, and Iran, half with 8 or few years of experience and half with more, and all of them were blinded to clinical information. They read in 2 rounds, at least a month apart. First, they read the abbreviated set and then the full set, with the cases reshuffled so the readers couldn't see their earliest answers. In each round, they scored 8 bowel segments, 3 in the small bowel and 5 in the colon for wall thickening, edema, ulcers, fat stranding, strictures, and penetrating disease. To measure agreement on the binary findings, they used Goetz AC1, a chance-adjusted score that stays reliable even when a finding is very common or very rare. And for the numeric scores, they used the interclass correlation coefficient, or ICC. Both of these measures range from 0 to 1, and by the usual benchmark, anything about 0.8 is almost perfect. For detecting active disease overall, inter-reader agreement was 0.91 with the contrast-enhanced protocol and 0.87 with the abbreviated one, both almost perfect, and the confidence intervals overlap. That held regardless of experience level. The chart breaks it down by feature. Agreement was almost perfect for wall thickening, substantial for edema and penetrating disease, and lower for ulcers and fat stranding. The ranking was the same in both protocols, and neither scored meaningfully higher on any feature. That was agreement between readers. Intra-reader concordance turns to the individual. When the same radiologist read the abbreviated and the contrast-enhanced versions, did they reach the same finding both times? This was measured for every feature and complication and for every reader. Concordance was almost perfect throughout, from 0.86 to 1, reaching a perfect 1 for strictures. So within a single reader, removing contrast didn't change the interpretation. The same holds for SMARIA, the index that turns these features into a single activity score and has been validated without contrast. Between readers, the result is consistent with what we have seen so far. Classifying a patient as having active disease was almost perfect under both protocols, with agreement coefficients of 0.91 with contrast and 0.87 without. Agreement on severe inflammation was also substantial. However, agreement on the global score was only moderate, near 0.5, since summing across segments accumulates small reader differences. Therefore, across all three, the two protocols gave comparable results. On the other hand, accuracy against endoscopy answers a different question. It answers whether the reading was actually right. In the terminal ileum, SMARIA reached around 97% sensitivity with moderate specificity. In the colon, sensitivity dropped off while specificity held. That sensitivity-specificity shape is characteristic of SMARIA itself, and it was the same with or without contrast. Accuracy, like agreement, did not depend on the protocol. These are encouraging results, though like any study, this one has boundaries worth keeping in mind. First, the abbreviated protocol was not acquired on its own. It was simulated by extracting the relevant sequences from full contrast-enhanced exams, so it has not yet been tested as a standalone scan in practice. Second, this was a single-center, retrospective analysis of a curated set of cases, which limits how far the findings generalize. Third, and this is the most important distinction, the study mainly measured agreement and not accuracy. High agreement tells us that the readers were consistent with one another, but not that they were necessarily right, and shared misclassification cannot be ruled out without a reference standard. The protocol also left out the diffusion-based imaging, which many current protocols rely on, and the readers were subspecialty experts who may agree more readily than general radiologists. So where does this go from here? The next step would be prospective, multi-center validation using a truly acquired abbreviated protocol and testing it against a hard reference standard ileocolonoscopy or histopathology to confirm accuracy rather than consistency. From there, the work may refine a tiered strategy that reserves contrast for uncertain cases and broaden the non-contrast toolkit to include diffusion and motility imaging. The final test is real-world impact, workflow, cost, and the patient experience. In conclusion, the question was whether intravenous contrast is necessary for MR enterography in Crohn's disease. For the consistency of reading disease activity, this study suggests it largely is not. A non-contrast protocol, just T2-weighted and balanced steady-state sequences, gave inter-reader agreement for active disease comparable to the full contrast-enhanced exam with almost perfect within-reader concordance between the two. This held across the board, regardless of reader experience and across an international multi-center panel, and the payoff is real. Dropping contrast and the antiperistaltic agent cut acquisition time by nearly 40% from about 19 minutes to 11.5, while lowering costs and easing the patient experience. The goal is not to eliminate contrast, but to use it selectively, adding it when the clinical question calls for it, such as in penetrating disease or subtle inflammation. Thank you very much for your time and attention, and I'd like to thank the Academy of Online Radiology Education for this great opportunity.